Hi, everyone, and welcome to our monthly research briefing. I'm Vanessa Weisberg from the Celiac Disease Program at Boston Children's Hospital. And this month, we're talking about a new study about the gluten challenge. I'm really excited to talk about this one because one of the lead authors is our very own Dr. Jocelyn Silvester. So, Dr. Silvester, tell us how you got involved in this study.
Thank you, Vanessa. So this is a study that we did with our colleagues at Mass General, and I was involved with through my role at Beth Israel because it's a study of adults. And it's a study that was actually sponsored by Takeda, which is, our listeners probably know, is a drug company that has several drugs related to celiac disease. And the reason to do this study is that we know at a fundamental level that giving people with celiac disease gluten isn't good, but we don't necessarily have really good markers to see what's happening when we give them gluten. And so that has implications not only for diagnosis, but for treatment. I should also mention that unrelated to this study, I'm also an advisor for Takeda, which means from time to time, we have meetings where folks from Takeda and myself and other clinicians and researchers come together, and they'll ask us a series of questions as they're trying to figure out the best way to test their drug.
So, if we know that people with celiac disease can't eat gluten, why are we going to give it to them in a study?
So that's a great question. And it's a question that's going to come up more often because the first thing that happens when you put somebody with celiac disease in a study is they eat less gluten. Because everybody can be more careful with their gluten-free diet, and putting people in a study makes them more careful because they want to be good for the study. Unfortunately, if you're studying if something helps protect you from getting small amounts of gluten, that's not actually the most helpful thing. And so that's one reason. Another reason is if you want to have a drug that means it's safe to eat gluten, you only know it's safe to eat gluten if you give people gluten in the drug and it appears safe. And so the purpose of this study was to see, are there any blood tests or any other tests we can do other than biopsy that might be more sensitive and less invasive to see how gluten is affecting people.
Got it. Can you tell our listeners why a gluten challenge is important for diagnosing celiac disease?
Yes. So right now, the markers we have for celiac disease, the great thing is when you take gluten away, they reverse and look more like normal. And so often in clinic, we see patients who've already gone on a gluten-free diet. And so in order to make the diagnosis, we need to put them back on gluten. Now, very few people are very excited about the prospect of going back on gluten. And so one of the things this study does is it gives us an idea of, well, how much gluten do people need to have and for how long? And, there's the old adage that the dose is your poison, and that's true for gluten too. So it doesn't only matter how much you have at a time or how much you have per day, but also how many days you have.
So tell us about the study and how much gluten did participants actually need to eat?
Yes, so this was a study that has a very classic celiac disease study design that we'll be seeing more of in the future, hopefully. And so the first thing is to screen patients and make sure they meet all the criteria to be in the study. And then because we know of this phenomenon where people are a little better with their gluten-free diet in a study, we usually have about a month, which is like a run-in period, just to get people to what their new baseline will be now that they're in the study. And then we had a 2-week gluten challenge. And before and after the gluten challenge, there were biopsies. And we also did video capsule endoscopies, which are like a pill cam that you swallow. And then there was also blood work throughout. And the goal was to compare 2 different doses of gluten. So half of the people got 10 grams per day and half of the people got 3 grams per day. And the purpose here was to see, as I mentioned, there's a difference in the dose, and so does that affect the markers we're looking at? And most importantly, is there a dose where we can see markers that change, that show the response to celiac disease, but maybe don't have more symptoms? Because ultimately, in designing clinical studies, you want people to have as few symptoms as possible.
So you said you looked at blood and biopsies. What did you find in your testing after these people had eaten the gluten?
So what we found was really interesting and has implications for drugs, but also for what we do in clinic, which is, I think, the hallmark of a good study. So essentially, those in the high-dose gluten group had more gluten and had more response. We stimulated their immune system more, and it protested more loudly. And so specifically, they had more changes in their villi getting shorter, more changes in inflammatory cells, more of the T cells that are causing these changes in their blood. And it was more clear that these folks were having a response to gluten. Symptoms were a much less clearer signal than some of the more biological endpoints.
So from what you're saying, the amount of gluten in the gluten challenge definitely did matter?
Yes, yes. And we know this because we know that there's small amounts of gluten contamination in a diet, and often patients will come to clinic and say, I think I got a small amount of gluten and I felt okay. But if we give those same patients a lot of gluten, they usually feel less okay. And so this really confirms what we see clinically in a way that we can apply scientifically, which is important not only for clinical diagnosis, but also for the drugs. So as you mentioned at the beginning, sometimes we need to give people gluten challenges because we have to figure out if they're really responding to gluten. And so this really guides us in understanding that if we give people gluten and we don't see a response, we really have to think carefully about how much gluten they were getting and for how long. Because it may be if we don't give them enough gluten, or if we don't give them gluten for long enough, that we'll miss the fact that they have celiac disease.
Absolutely. So can you tell our listeners why this study is important for developing better diagnostic tools for celiac in the future?
Yes. So one of the things we looked at in this study is something that had been identified by Bob Anderson and Jason Tydin when they were doing the NextVax studies. And they looked at cytokines, which are like chemical signals that are released. And one of the ones they looked at specifically is something called IL-2. And this is released very quickly when these T cells that recognize gluten, these immune cells see gluten, they spit out IL-2. And so when we gave people the first dose of gluten, within 4 hours, we saw a significant rise in the amount of IL-2 in their blood. And this is exciting because it's related to the mechanism of celiac disease, because we know where it's coming from. Also, in other studies, it's been correlated with vomiting as a symptom. And it's potentially a way that you could assess if somebody has celiac disease with one dose rather than many weeks of gluten. So it's something that is not available clinically, that has been used much more on the research side, but if it could be translated to the clinic, would have potential to revolutionize how we diagnose celiac disease, particularly in those people who are already on a gluten-free diet. Interestingly, as the gluten challenge went on, the IL-2 level went back to normal, and so it was less good of a marker.
So let me make sure I understand this. You're saying that theoretically in the future, someone could come to clinic, take a gluten pill, and within 4 hours you could see a spike in IL-2 and then be able to diagnose celiac disease 4 hours later instead of weeks eating gluten?
Potentially. And as I say, this is something that has not been demonstrated in the degree of rigor that we need to apply it as a clinical test. But in research studies, it's a fairly consistent finding across cohorts and across study designs. So if we had the resources to translate this into clinic, I think it's something that would potentially revolutionize what we do.
Okay, so we talked about how this could be useful in building diagnostic tools. What about a drug? How does this study help us get to a drug for celiac disease?
So in general, there's sort of two ways of thinking about a drug for celiac disease. One is to take care of this small amount of gluten that we think most people are getting but may not know. Another is so that people don't have to go on a gluten-free diet at all. And so either of those drugs, one way to test them is to see if markers that the immune system is getting stimulated by gluten go away. And so this gives us an idea of how much gluten and for how long to see if that drug's really working. Because if we only give one dose of gluten and then we look to see if they have villus atrophy, we may falsely think the drug is working because you actually need more than one dose to see villus atrophy.
Wow, that's all so fascinating, and just it's so cool to see how many great things can come out of the work that you're doing. So thank you for taking the time again this month to share your work with all of our listeners and viewers. And we really hope that everyone enjoyed this month's research briefing, and Dr. Silvester and I will be back again next month.
Thank you. It's exciting to see all the progress we're making in celiac disease, and I think it's really important to note that this study really was made possible, not through government funding, not through private funding, but through industry. And really, for the first time, we're seeing serious industry interest in celiac disease, and that's really helping push the field forward.